News Channel 5 network and millions of conversations. This is one of millions of conversations.
Welcome to the Millions of Conversations show. I'm your host, Samar Ali, and we're so glad that you're tuning in. One of the things we try to do on the show is have hard conversations about difficult topics that affect many of us. And in this case, and in this instance, it really affects all of us. Joining me today is back again, Dr. Stacy Davis and Dr. Connie Graves to continue our conversation about why is there a growing trust deficit between American patients and our American healthcare system, specifically between patients and our healthcare providers. And what can we do about it as patients in order to figure out how to get the healthcare that we need so that we can have happy and enjoyable lives for as long as possible. This issue on trust is something that we are seeing happen across America. It's one of the reasons that we are so divided, and we're finding that it's not only affecting our healthcare system, it's affecting other systems as well, including education. We're going to be touching on some of those in later episodes, but today we're focused on healthcare. In our last episode, one of the takeaways for me was that there's a reason that so many people are turning to Dr. Google for their information rather than to their healthcare providers who've spent many years getting an education to be experts and to take an oath to make sure that their patients stay as healthy as possible. But there's a reason that people are going to Dr. Google. In part, it's because that's the accessible information that they're finding is the easiest for them to be able to navigate. It's a cumbersome system, that American healthcare system. But one thing for me that I took away from that last episode was that what if we view our doctor, what if we view our healthcare provider as our quarterback? So I would like to turn to both of you and ask you, both of you, what do you think about that analogy of thinking about our doctors as our quarterbacks? Do you think that it works? Do you see yourselves as such? And what does that look like from your perspective? What does it look like from the patient's perspective? How should we be thinking about that?
Well, you know, I always tell my patient that I'm her quarterback, because most of our patients who come to see us have complexities of pregnancy. Either the mother is complex or the baby is complex. And so none of us, there's no one person that's going to be able to address every issue. So my job is to make sure that I get her to the cardiologist to make sure that if she addresses her heart issues.
So that's how you all ended up working together?
That is correct.
That's right.
Yes.
Okay. Because you're a cardiologist and you're a surgeon, right?
I'm a surgeon. Yes. who is an obstetrician who is specialty trained. Yes.
Okay.
And so, you know, being a surgeon and someone who deals in complexities, I tell my patients all the time, I'm used to dealing in gray all day, because there's so many answers there, and there's so many things that change based on little nuances in your care.
And so should your patient be thinking about operating in the gray, or is that your job? Is that your responsibility that you do on behalf of your patients?
That is my responsibility to do on behalf of my patient.
Okay.
To decide, hey, this is where these issues may not be black and white. What is the best option given all of the other factors that come along?
So I'm guessing there are risks too, as you're helping navigate those risks.
There are always risks, and there are benefits. And so often our job is to weigh the risk and the benefits and decide how to make the benefits higher and the risk less.
Going back to the football analogy, which I think is excellent, and we were talking about this earlier, a quarterback has on his wrist a list of possible plays. He's also got his ear mic in place, and he's got people up above looking down and telling him what potential defensive positions the opposition is taking. And so the quarterback has got to weigh all options based on established plays, input, and then he's reading the defensive line in front of him. And in the moment, we, as your quarterback, have to take in all the information that we're reading in the medical literature. things that you're telling us about your tolerances or intolerances of medications, about your preferences. And then what we've gained from many years of experiences treating patients like you, and we've got to synthesize it. We've got to pull it all together and in conjunction with you, develop a plan that is in your best interest.
And do you help people also navigate their bills as well as their quarterback? Is that something that you do? Is that part of your job?
We try to help you navigate your insurance company and your bill. What people often don't understand is there's like 5 million insurance plans, and there may be 10 insurance plans for the same insurance. And so the first thing we try to do is understand what your plan offers and what it doesn't offer.
Okay.
And you may not even know all of the nuances. As I was explaining to Dr. Davis, I said I had a patient the other day, and even my accounts receivable person who does insurance every day had no idea that Federal Blue Cross Blue Shield doesn't pay a copay, but only when you are pregnant. Any other time you would pay a copay.
I see.
So you can see how that could be very confusing.
Yes, and so you help patients to understand and navigate that confusion. So how does a patient find you? How does a patient find doctors like you? How do they find their quarterback?
Well, the first step is to know what you need in terms of care. For example, cardiology very often gets patients from primary care providers.
Right.
In my area of expertise, heart failure and cardiobstetrics, which is heart disease in pregnant patients, there's an overlap. And very often, my patients come from a specialist like Dr. Graves. That said, it is not unusual for patients to tell their friends, oh, well, Dr. Davis took care of me during my pregnancy, or Dr. Graves took care of me during their pregnancy. You should see them too.
So do you recommend second opinions, or are those things that you recommend, or are those things that insurance pays for?
I'm a big fan of second opinions.
Okay.
I think that number one, when you're uncomfortable with the plan that your provider has made, they should encourage you to get a second opinion. Mm-hmm. I often say to my patients, if you'd like me to send you to Vanderbilt, which is the other larger maternal fetal group, I'm happy to send you over so they can look at your ultrasound, because this is what I see. But it's always great to have another set of eyes. Mm-hmm. And so I think that your provider, if you're uncomfortable, should be encouraging second opinions. And yes, insurance does pay for those.
Your physician has to be someone that you can communicate with. Okay. And also, it's important that when you come see the physician, I always do this for myself when I go see my physician, have a list of questions so that you can get answered those issues that are most important to you. We always joke about the scenario in medicine that the most important question is the one the patient asks as you, the physician, are going out the door.
Because you have your hand on the doorknob.
Yes.
However, one of my practices is when I finish telling you all the things that you are there for during the visit, is to say, do you have any questions?
Mm-hmm. So that scenario, and I have heard that before about the doorknob question, as the doctor is walking out and they have their hand on the doorknob, that's when the patient says one of the most critical things. Why is it? Do you oftentimes find that your patients have a lot of fear, they're uncomfortable? How do you navigate that?
I think part of that is choosing the right physician.
Okay.
It is said that, especially for women, there may be a power differential, and especially for people of color, there may be another power differential that keeps people from asking questions. So the first thing is choosing your physician so that they make you feel comfortable by asking you if you have any questions.
Okay.
And of course, often I think patients, I tell people all the time when I give news, a lot of times once I say there is something wrong, that's all the patient hears. That's it.
Okay.
All they hear after that is a rushing of wind or blood in their ears, and they haven't heard nothing else you said. So that's one of the phenomenons, is that now that I've gotten up and now you've had time to process what you thought you heard, that's when the questions come.
I think, and this goes hand in hand with what you've said, bring a second set of ears with you. Okay. I learned this in my own life. I went to a doctor's appointment for my mom with my dad, and at the end of the visit, I learned that my mom heard something completely different than my dad. My mom.
And does HIPAA allow for that?
Yes.
Okay.
Yes, of course, with the patient's permission.
Right.
But what I realized was my mom is a glass half full sort of person, my dad half empty. Okay. One heard the positive, the other heard the negative. And I felt like I was the only one in the room who heard everything the doctor said.
So it's sounding to me like what you're talking about is that we need to have a good relationship. We need to figure out how to have a healthy conversation that's at the heart of this, and we need to think through how we listen.
How we listen and who we bring to help us listen.
And who we bring to help us listen. Well, I'm going to be looking forward to talking more about that after the break. Thank you. Thank you for joining us after the break. We have with us in conversation Dr. Connie Graves and Dr. Stacy Davis. We're having a conversation about healthcare, the American healthcare system, and how we navigate it between patients and our healthcare providers, particularly how we manage and diagnose and try to heal this growing deficit between our healthcare providers and patients. So we were talking a little bit at the beginning of the show about our physicians being our quarterbacks, and about our team and who's on our team, bringing an extra pair of ears to come in, navigating whatever issue that it might be that lands us in the doctor's office, thinking about who is it that we want with us on that journey, on that medical journey, including our doctor as our quarterback. So those are some of the things that we can do together, but there is the system at play too. Can you tell us a little bit about that and maybe some of the disparities that others are navigating that some others might not, that they need to be aware of, and what should be top of mind depending on what your situation is?
So American medicine reflects America. And so the historical pieces of America are the historical pieces. So we know that a lot of mistrust comes from the fact that in our system, women, especially women of color, have been treated as if our pain is ignored. In fact, the father of gynecology, James Marion Sims, operated on slave women without the benefit of anesthesia, and then perfected these surgery and then was celebrated for it. Or, Benjamin Rush, who came up with psychiatric diagnosis for runaway slaves to say that if you didn't want to be a slave, that somehow there was something wrong with your mind. So you can see how people are like, well, that's not a system I would want to be in. Or the Tuskegee experiment, which also people don't know was replicated in Guatemala.
Oh, wow.
And so that's another place where people were not given treatment even though they thought they were.
And that must contribute to why people also aren't feeling that they can trust the system.
Absolutely. And then to add kind of insult to injury, when you cannot access the system, when you often are relegated to seeing certain providers. I tell people I was born in 1962 in a clinic. My mother was a almost 40-year-old woman with a master's degree who could not go to a hospital in the area because they did not take black patients.
Oh my goodness.
And so, so I was born in a clinic, the Cook Clinic in Carruthersville, Missouri, but not in a hospital because there was no hospital that was in the area until Memphis, Tennessee.
Wow. So you bring up several good points for us to be thinking about, including, I like how you talk about this regarding American medicine. And one of the things that we're seeing increasingly, everybody's talking about it, is that the role of artificial intelligence. There's this new thing called artificial intelligence that some people think is going to come in and make things better. Do you agree with that?
I think it's complex, and indeed,
so complex,
in many
adding to
ways,
the complexities. Okay.
Adding to the complexity. For example, when I look at you as a patient, okay, the first thing I do is I look into your eyes. I look at the color of your eyes, the whites of your eyes, the colors of your cheeks. What's your expression, okay? AI sees you on a computer screen. AI doesn't capture all these nuances. You tell me what's going on. You give me a list of symptoms, but you're not going to necessarily list them in order. You're going to tell me a narrative, a story, and I'm going to have to pull it together, and I'm going to pull it together based on your past history, but based on other facts. Can the computer do that as well? Right now, not necessarily so. In the future, perhaps, okay? But there are all sorts of things that the AI program will do. And if you remember the TV program House, what did Dr. House say? All patients lie. Why did he say that? Because patients want to present the best version of themselves.
Do you know that lawyers will say that too a lot of times?
So
people feel shame.
People underreport their alcohol use. People underreport their tobacco use. AI doesn't necessarily question those issues. But getting back to AI, AI is maybe extremely helpful for complex diagnosis, but...
Tell me more. How so?
How so? Your patient that doesn't fit the standard presentation, the patient who has some unusual symptoms, okay, helps us pull things together. Someone like Dr. Graves or myself might turn to an online search because we know that that presentation isn't usual, and is there something we're leaving out that we ought to consider? But AI also can do what we call hallucinate. I had never heard that term before.
AI hallucinating.
Right, that AI will make things up, and that can be a problem.
Because it doesn't want to be embarrassed. And so
it's its best with its user. So it sounds like it's AI work.
And the training set.
Yes.
And let's get back to the training set and how racial bias may affect AI.
Well, but keep in mind that we know that racial bias affects the outcomes in medicine. So, you know, it's not just that you come in with a set of complaints, but I also have to navigate, number one, are you telling me those complaints? How you express those complaints. In the South, you know, there are certain things that we don't talk about, you know, regardless of race. And so, you know, the regionality of where you are. So AI doesn't always take those in. And then AI, I have to program it. So I have to put in all the things that, you know, you may or may not tell me. And then I have to put in some other things that can be factors that are not scientifically tangible.
So one question for me is, how are you going to recommend for patients to navigate that? And then also the insurance companies, because I've been hearing a lot that insurance companies are increasingly going to be relying on AI for some of the decisions that they make. And how is that going to impact your practice?
Well, insurance companies, you know, for years have had these algorithms. Many of them are very frustrating, I'm going to just say, because it's about knowing the first code to put in to get something paid instead of what actually is this patient's diagnosis and whether or not this is reasonable care. So I can see that this is going to hamper care, probably, and delay payment, and may keep patients from getting the care that they need because you're putting in it again.
It's going to make the quarterback's job harder too.
And make the quarterback's job harder. And those things that we talked about, the intangibles, you know, transportation. You know, yes, I can give this medicine that the patient has to come in for 5 times, but you know, I work a job, I can't get off 5 times. So the other medication that I can give to the patient for 2 times might be a better option for this patient. And those are the things that AI doesn't always take into account.
Exactly. I think that I view AI somewhat like the electronic medical record. Okay,
Right.
We were told that the electronic medical record would revolutionize care, that there would be open access to information, that you could go to your cardiologist and the cardiologist would write notes, and those notes would be readily available to your maternal fetal medicine specialist and would be readily available at the hospital when you were admitted. The reality isn't what we were sold, and the reality has...
So what is the reality?
The reality is that there are multiple electronic medical record systems for both inpatient and outpatient care. In Nashville alone, there are 4 different systems. If you go to the VA, it's a different system than Vanderbilt, which is a different system than Centennial and Ascension.
And none of them speak to each other.
Right, exactly. And so the promise of the electronic medical record has 10 years down the road yet to be achieved. So I think AI has tremendous process, but it's all in, and they use this word all the time, in the rollout or the application of the technology.
When I say the user. So what do you suggest and we as patients can do about it? Is there something that we can be doing? First and foremost, is it simply being informed?
The first thing is to trust your provider.
Okay.
That is the first, because what we're going to do is we're going to use the information to get to get the best. There's new AI, I think, for ultrasound diagnosis. Well, that's great to help me think about all the things that this could be. But then I'm going to use that and narrow it down. So I think that's the first thing, to trust your physician.
It's that relationship. It sounds like that is at the core of all of this. And I just want to say thank you both for joining us in this important conversations on the Millions of Conversations show. Thank you for all that you're doing, and thank you for helping us find a pathway forward during this very complex and confusing time. We appreciate you. Thank you.
Thank you.
Thank you.
Thank you again for joining us on the Millions of Conversations show. What incredible conversations we've just had with Dr. Graves and Dr. Davis. Today we focused on solutions, how we build trust in healthcare, empower patients, and navigate a system that oftentimes feels overwhelming. We discussed the importance of advocating for yourself, asking the right questions, and working with doctors who will truly listen. I took notes, and here's some of the things that I took away from this. One is that relationships matter, and that relationship between doctors and patients is no exception. We're in community together, and we have to figure out how to listen to each other, how to work together, how to identify who is playing what role and who can do what and what we need in that moment. Listening is key to that. I've learned that it's helpful if we bring an extra pair of ears sometimes. If we think about our doctors as our quarterbacks who are helping us navigate this complex system that is ever changing, so that they can help us, for example, even with things of not only figuring out what kind of health care that we need, but also helping us to navigate our bill. We should come with a list of questions as patients, and we should really be asking questions about AI. In what ways is it going to help? In what ways is it going to make an ever complex system even more complex? So real change starts with conversation. That conversation happens between our patients and our physicians. When we listen to each other, we can begin to bridge that gap in trust and build an American medical system that works for all of us. Please join Millions of Conversations by taking our pledge to listen, because when we listen, we move forward together. We hope we'll see you next time.